Hello, this is Dr. Al Karaguli, starting in tonight with caseless defense. Hi, everybody. Can you hear me? Can you please raise a couple hands so I can see if you can hear me? Thank you. Okay. So we're doing caseless defense tonight, and I would like to see if anybody wants to volunteer. Okay, I have Alexandra. I'm gonna unmute you. Hello?
Hi. Hi.
Hi, Alexandra. How are you?
Good. How are you?
How can I say your last name, please? Because I don't know how to read it.
Shupak.
Shupak. Okay. Okay. Where are you at? Are you a generalist?
No, I'm an REI fellow.
Oh, okay. So which case list do you want to go over? Let me first pull up. Can you see my screen?
No, I can't.
What about now? Can you see my screen now?
I can.
Yes?
Yes.
Okay. This is your case list, correct?
Yep.
Which one do you want to go over?
Anyone you want.
Should we do OB since you're REI?
Sure.
Okay. How do you feel about your case list? Are there any cases that you're worried about?
Not particularly. I just don't feel comfortable with OB in general, so.
Okay, let's go through the first case. Let's talk about breech.
Okay.
Okay, what are types of breech and which one is the most common type of breech?
The breech is when there's a non-cephalic presentation, so there can be a complete breech, there can be frank breech, there can be footling breech.
Which one is the most common type of breech?
I believe frank breech.
Okay. What are some complications with breech delivery? When you're counseling somebody who's interested in a breech delivery, talk to her about what complications can happen if she decided to deliver breech versus having a C-section.
If she were to remain breech at term, I could counsel her that if she ruptured membranes and was dilated, she could have a cord prolapse. She could have a severe perineal laceration. She could have had entrapment with severe fetal morbidity and mortality.
Okay. What is the mortality rate with breech?
I believe it's, I don't know the exact number, but I think something like 10 times higher mortality rate.
Okay. What are some risk factors that put a woman at increased risk of having a breech presentation?
Multiparity, something like a submucosal fibroid or a uterine septum, polyhydramnios, some kind of congenital anomaly in the fetus that would have like a large head, like if it had hydrocephalus.
Okay. Anything else?
Preterm baby.
Okay. So let's say you have a patient who was a multiparous patient who had like 3 vaginal deliveries before and does not want to have a C-section for a breech and wants to have a breech delivery.
Mm-hmm.
If this patient were to deliver via breech, who would be the excellent candidate? Like what criteria need to be in line for this breech delivery to go uncomplicated?
The ideal candidate would be somebody at term, somebody that is multiparous, a fetus or a baby that's measuring normal size, someone that came in spontaneous labor. And that's all I can think of right now.
Okay. Tell me how you would deliver breech. If somebody, let's say, rolled in labor and delivery and you're the in-house covering attending and you know, baby's coming out already, you don't have time to take her to the OR, and it's going to happen, you're going to deliver a breech, which happens once every long time. How do you deliver a breech?
Okay, if I did not have the ability to take her to the operating room for a C-section, I would alert anesthesia. I would call if there was another OB on backup to come to the operating room with me and let the charge nurse know. I would tell the patient to start pushing, and I would not pull the baby. Once she pushes to the level that about to the shoulders, I would put my hand in the popliteal fossa and deliver both legs. After that, I would tell her to keep pushing until like the level of the scapula, and at which time I would put a towel over the baby's back, rotate the baby to one side, trace my hand down over the humerus, put my finger in the antecubital fossa, sweep the arm across the infant's chest and then out to the side, and then rotate the baby, deliver the same way. I would then have the mom keep pushing again and attempt to flex the head by using my first and third finger on the baby's zygomatic arch in order to flex the head.
A lot of the stuff that you mentioned are maneuvers. Do you know the names of the maneuvers you just mentioned?
Yes, when I deliver the legs, I believe it's called the Pinard maneuver. The way that I would deliver the arms, it's called the love set maneuver, and the flexion of the head, I believe, is Mariso smelly feet. Not sure about the eponyms pronunciation, but I think that's what they're called.
Yes. Okay, Marisol smelly beach. Okay, let's say you have a head entrapment and the Marisol smelly bead is not working.
Mm-hmm. At this time, I would make sure that I have an assistant holding the baby, and I would try to apply suprapubic pressure or have an assistant apply suprapubic pressure while I try to flex the head with the same maneuver.
What do they call that maneuver? The suprapubic pressure to relieve the head and breech. It has a name.
I'm not aware of the name.
Okay, it's called the Creed maneuver. C-R-E-D-E, Creed.
Creed. Okay.
Okay, so let's say you did the suprapubic pressure, you did the Marisol smelly bead, but the head is not coming.
So if the fetus is preterm, I could consider a Drusen's incision to
Why
incise
did
this.
you say if the fetus is preterm? Can you not do it when it's term?
Typically, if it's a preterm fetus, the body is smaller than the head, and so those are the ones that are more likely to have entrapment. And so this maneuver typically is more effective in preterm babies.
Okay, you tried that and it didn't work.
Okay, and if
What's next?
I would then perform a laparotomy and put direct suprapubic pressure on the uterus and attempt to flex
Is
the
there
head.
something else you can do with laparotomy?
Um, if I thought that it was a soft tissue problem, I could try cutting an episiotomy to have more room to attempt to flex the fetal head and deliver the fetal head.
Okay, you're gonna do an episiotomy. Anything else that comes to mind?
Not at the moment.
What about pipers?
Oh, I'm not qualified using Piper forceps, but
What do
if
you mean not qualified? Explain.
I've never done a forceps delivery before, and so I think that I would do more harm than good if I were to attempt a forceps extraction of the fetus.
Okay, so none of us have done it. So as far as I know, a lot of people that I've talked to, have not done. First of all, forceps is still being done in some hospitals, but for the majority, there's less and less people doing forceps, unfortunately. It's like kind of becoming like a lost art. Same with breech, because we don't even do breeches and they're so rare, then the Piper's forceps also becomes something that, a lot of us haven't done. I know I've done it on a dummy in training, but for the purpose of the oral board exam, even if it's something you have not done or don't feel comfortable doing because you don't have enough experience, that's okay. You can say that, but it's an option that you should mention,
Okay.
right? So you can say, so for example, let's talk about head entrapment and breech. So the first thing you're going to do is the Mariso smelly bead. And then you're going to, if that doesn't work, you can ask somebody to apply suprapubic pressure to flex the head. So that's the creep maneuver. If that doesn't work, I wouldn't say that the next step is the Drushan's incision. It is kind of a last step that you're going to do, and you are absolutely correct. It's only successful for premature infants around 26 to 28 weeks. But then you have a couple things that you can do before you go ahead and do a laparotomy. And so you can do the Piper's forceps. You can say, Piper's forceps is an option. I have never done it myself, but um, I know how to describe it. Um, and then the next thing that you can do other than the Piper's forceps is two maneuvers. One is named the Bracht maneuver, and the other is named the Prague maneuver. The Bracht maneuver, B-R-A-C-H-T, is when you extend the leg and the trunk of the fetus above the mother's abdomen to deliver the head. If you can't imagine that, I would Google it and watch a video on it or just look at pictures. And the Prague, Prague, is when the presentation is sacrum posterior, and you're going to put two fingers of one hand to grasp the shoulders of the back of the baby down from below, and the opposite hand will grasp the baby's feet and draw them up over the maternal abdomen. Can you
Okay.
imagine what I'm talking about?
Yes.
Okay. So one if the sacrum's anterior and the other if the sacrum's posterior. And then you're going to talk about Piper's forceps. And if they ask you, do you know how it is applied theoretically, even though you haven't done it?
I believe that the assistant is grasping the baby from below and you are at the midline. I think you place the left first and then the right and articulate the forceps, make sure that there's no fetal or maternal tissue in the way. And then I believe that you would flex the head and kind of deliver it in a J shape. That's the extent of my knowledge.
That's okay. That's good. So the assistant holds the baby wrapped with a blanket. The operator, you, kneels and applies the Pipers on the head, beginning with the left blade and then the right blade, and then you lock them. The infant body is straddled over the forceps. Now they act as one, the baby and the forceps. And then you apply downward traction in the direction of the handles until the chin appears, and then you elevate it to deliver the head.
Okay.
Okay.
Mm-hmm.
And then there's the Drushan's incision. And if the Drushan's incision fails, well, the next step is to do a symphysiotomy. I think that's easier than doing a laparotomy. How do you deliver a nuchal arm? How do you manage a nuchal arm?
You mean, sorry, I'm not understanding what you mean by a nuchal arm. Like the arm
Nuchal arm and
is up
breech?
around the neck.
It's above the head.
Oh, um, I would insert my hand up and again trace my hand over the baby's arm and try to engage the elbow and sweep the arm down to the baby's side and deliver it that way.
So if it's a right nuchal arm, you rotate the shoulder counterclockwise, so to the left. And if it's a left nuchal arm, then you would rotate the shoulder clockwise to the right, the opposite direction.
Okay.
If it doesn't work, you will push the fetus upwards in an attempt to release the arm.
Okay.
If you have twins, the first is cephalic and the second is breech, how are you going to deliver?
I would counsel the patient and if she decides through shared decision making to proceed with delivery, I would deliver the first baby cephalic and perform an internal pedalic version and deliver the second baby cephalic as well, given that there's no, as long as there's no contraindications to delivery of the second twin vaginally.
Did you say you're gonna do an internal pedalic version of the second twin?
Yes.
What is an internal pedalic version?
An internal pedalic version is when you have your second baby that is in a non-cephalic presentation and you use the presenting part, which is the foot, to rotate the baby and then engage the head.
And so you're gonna turn the baby inside and deliver cephalic for the second?
Yes.
Or are you gonna deliver the baby like a footling and pull the feet through the vagina and deliver as breech?
I would try to deliver the baby cephalic.
Okay, so then the options for delivering the second twin baby breech would be either an external cephalic version, which is what you just described, or an internal pedalic version, or cesarean delivery. An internal pedalic version, I know that when I read, I also thought that it is what you're describing, but it's actually where the hand is inserted in the uterus. Both feet are grasped with the membranes intact, and then they're pulled gently towards the introitus. And once the feet are in the introitus, you're going to rupture the membranes and manage as footling breech and deliver. So basically, it's kind of like a breech extraction.
Okay.
So internal pedalic version is not turning the baby from the inside to become cephalic. It's basically fancy name for breech extraction. But it's when the other baby is still high up, and you're kind of like gently guiding the baby down.
Okay.
The breech extraction was favored if the gestational age is more than 28 weeks, if the discordance is less than 20%, and the estimated fetal weight is more than 1,500 grams, and an experienced OB who does breech delivery. Okay, let's talk about external cephalic version. In that first case of yours, you said the patient declined external cephalic version. So you offered versions. So what's your success rate?
About 50%.
Okay. How many have you had? Do you have any other ones in this case list that are successful?
Not on this case list. This is from residency, and I included 20 cases, but I have performed successful in residency.
Okay, sounds good. So what would be the criteria for a successful external cephalic version?
The baby would have to be at term. No congenital anomalies or anything wrong with the baby, such as like an omphalocele or something like that. They would have to have intact membranes, no bleeding, no placenta previa, creta, or any abnormal placentation. And that's all I
Those
can think.
are the contraindications, but the
Oh,
factors that are predictive of success
I'm sorry. Yeah,
would
so
be what?
a term baby with intact membranes in a multiparous patient with a
A
non-anterior
normal
placenta.
AFI or a high AFI, right?
Right.
So it's easier to flip the baby, and a posterior placenta.
Mhm.
And if the mom is not overweight, that will be also something that will help. When I
Right.
asked you first about breech, I did not correct you. I asked you about types of breech, and I asked you about the most common type. The most common type you said was complete, but the most common type of breech is frank breech, 50 to 70%, where the hips are flexed and the knees are extended, followed by complete breech, where both are flexed, the hips and the knees, and then the rest would be an incomplete or footling breech. I also asked you about mortality and complications with breech delivery. And so mortality with breech delivery is around 5% compared to like 1.6% with C-sections. You counsel the patients, you tell her she can have an intrapartum fetal death, she can have a head entrapment or asphyxia. There could be some neurologic disease like palsy or torticollis, could be bone fracture, joint dislocation, cord prolapse, or fetal heart rate abnormalities. And then I also asked you what are some risk factors for breech. So that would be like uterine anomalies, fibroids, placental abnormalities like PIVIA, lax abdominal walls, like grand multiparous patients, patients with amniotic fluid abnormalities, either like oligo or poly, and also prior breech. Those are all risk factors for a breech delivery. Also, some stuff related to fetal, because every time you think an OB, think maternal causes and fetal causes. Stuff related to the fetus itself would be some kind of fetal anomaly that will prevent the baby from turning head down, like a hydrocephaly or anencephaly, or if there's twins and they're preterm and they're just flipping around, or if there's a short umbilical cord. The perfect criteria for breech delivery would be if a baby is between is around 36 weeks, between 2,500 and 4,000 grams, or if the baby's like 31 to 35 weeks and the weight's like between 1,500 and 2,500. There should be continuous fetal monitoring. For this to go smoothly, it should be normal progressive labor, flexed head, frank or complete breech. And of course, the rest of the stuff where no contraindications to vaginal delivery, and doing this in a facility where that is prepared for emergency C-section.
Okay.
Okay, you know how to describe an ECV procedure, right? How it's done. What pain meds do you give for those patients?
What pain medications?
Yes, you give them pain medications when you do an ECV?
Typically at my institution, we did this with an epidural.
Okay. So let's say you're doing ECV and the patient develops dyspnea. What's your differential diagnosis?
Panic attack, an amniotic fluid embolism, pulmonary edema. You said, sorry, did you say shortness of breath?
Dyspnea. I said dyspnea, shortness of breath. Yeah, it's fine. So yeah,
Um,
maybe not pulmonary edema. Why did you think of pulmonary edema? Just because I said dyspnea?
no, because if she like somehow had preeclampsia and had pulmonary edema, I'm just thinking pregnancy, near term dyspnea, differential diagnosis.
Okay, well, I'm putting it in the setting of doing the ECV.
Okay.
So most likely could be discomfort from the procedure, reaction to terbutaline if you gave her terbutaline, development of labor, or amniotic fluid embolism. Um, what are some criteria to diagnose amniotic fluid embolism if that were to happen?
The patient would have to have hemodynamic instability, signs of coagulopathy, and it's a diagnosis of exclusion, I believe, clinically.
Right. So hypoxia, hypotension, the mill-wheel murmur. Patient could have coagulopathy. This could happen during labor, during C-section, during delivery. And so in the absence of any other explanation or findings, that's what our assumption. What would you do if you thought this is what was happening?
I would tell anesthesia, activate like an emergency team. If she was stable enough, have her transferred to a higher level of care. If she was having like desaturation and like trouble breathing, I would have anesthesia. See if they feel ECMO is team consult. We would consult critical care, activate massive transfusion protocol, give intravenous fluid resuscitation, and
Right.
then if she was bleeding from like all surfaces, I would probably just pack her and try to hold pressure on all surfaces to try to kind of temporize the bleeding while I could.
Right. So most likely you're gonna call ICU, gonna give her oxygen. When ICU comes, they're probably gonna intubate her. You're gonna try to put her on the left lateral decubitus position and prepare for a perimortem cesarean delivery if she goes into cardiac arrest or if she deteriorates. Okay. I will call on somebody else. Thank you so much for participating.
Thank you.
Covered most of the questions of breach if it ever comes in the exam. Again, in the exam, some of those topics that we don't do, it's okay to say that I don't do them, but you need to know the theory behind them. like forceps, interstitial cystitis, stuff like that, that usually a lot of us don't. A lot of general OBGYNs like refer to other people to do, or like, for example, in GYN, like bowel injuries or stuff like that, that we normally call, other people to help us. And that's fine and acceptable, and everybody understands that, including the examiners, but um, you still have to say that you know how it's done and describe it. So you have to know
Okay.
the knowledge.
All
Okay,
right. Thank
thanks a lot. I'm gonna call on somebody else. Who else wants to participate? Let's see here. Hadi Ramadan. I'm unmuting you. Hello?
Yes. Yes.
Hi,
Hello.
Hadi.
Hey, how are you?
Good. What, are you a generalist or a fellow?
REI fellow.
Okay. Just like Alexandra. Where are you?
I'm in Boston, MGH.
Nice. Okay, let me pull up your case list.
Maybe I shouldn't have said the hospital so I don't embarrass them.
Have more confidence in yourself.
Yeah, we'll see.
Okay, here you go. Okay, so what should we do? Do you want to do OB like her, or do you want to do office or GYN? What would you prefer?
OB is fine.
Okay, do OB. Okay, do you have any case on your case list that you're worried about?
Um,
Your
let me
stuff.
see.
Fast.
There is one I haven't prepared a lot, so we can talk about her. She is. Sorry, I'm looking for her. She's one who has like a heart disease and.
What
I'm
numbers?
looking for her. Sorry, I can't find her. Oh, whatever you want.
You can't find her? You don't have a lot of patients. Wait, which
Oh,
one
yeah,
is?
yeah, yeah. Oh, she was in the office. I'm sorry. She was in the office. Never mind. You can choose any one of the obstetrics.
Okay, let me look here. Is there a topic that you're not good at, so I can ask you that topic?
Random. I can't choose one. Yeah.
Okay, let's talk about GDM. You want to talk about GDM? Or maybe we can talk about postpartum hemorrhage. Which one would you prefer?
I think we've done postpartum hemorrhage a few times recently,
What
so
about
maybe GDM. Yeah.
GDM? So this patient here with GDM
hmm
that you have here was managed with what?
So she was
Diet
she was
or
an
insulin?
A1 diabetic.
Okay. And so when you screen for those patients, what gestational age do you screen for GDM?
Usually between 24 and 28 weeks.
Who would be a high-risk patient that you would screen earlier?
High-risk patients are patients who are obese, who have had history of gestational diabetes, who have a family history of diabetes, patients with hypertension, I believe, as well. Those are the risk factors that I can think about that patients that we can, if they have any cardiovascular disease, any dyslipidemia, those are the patients I would screen in the beginning of the pregnancy.
Okay. And so what's your cutoff for the 1 hour?
For the 1 hour, it's usually between 130 to 140. Depends on the clinic, but I think 135 would be a good.
Just say what your hospital does. So stick to one
Yeah,
number, say 135, and that's it.
yeah, okay, 135.
If it's elevated, then what are the values for the 3 hour?
Okay, I think so. The 3 hour 180, the 2 hour 155, and the 1 hour is 140.
I think you mix them up. What about the fasting?
The fasting is above 95.
Is that Carpenter and Kustan or then the national DM data?
I don't know.
Okay, so I think you're talking about Carpenter and Kustan. So fasting 95, 1 hour 180, 2 hour 155, and 3 hour 140.
Okay, sorry. Yeah.
Yeah, that's fine.
That makes
Okay.
sense. Yeah.
Yeah, so the risk factors would be prior GDM, previous big baby, obese with BMI more than 25, first degree relative with diabetes, high risk ethnicities like African American, Latinos, and Asians, hypertension, chronic hypertension, or um, just newly diagnosed hypertension, gestational, HDL less than 35, triglycerides more than 250, women with PCOS, HbA1c more than 5.7, and history of cardiovascular disease, just like you mentioned.
Okay.
Okay, so um, so how do you counsel her about the complication of diabetes on the pregnancy?
If we diagnose A1 diabetes at 24, 28 weeks, we're talking about that specific time.
Yes.
So there's multiple risk factors. Maternal, she is at high risk for developing A2 diabetes and needing insulin. She is at high risk of developing preeclampsia. She would be high risk for a C-section. And she would have high risk if the diabetes is uncontrolled. If she has a C-section, she might be at high risk for incisional infection. Those are the main risk factors maternally. Fetal, we are at high risk for IUFD, macrosomia. Macrosomia can cause oasis. It can cause at birth, it can cause hyperbilirubinemia. It can cause hypoglycemia, hypocalcemia,
Okay, good.
ARDS. Okay.
Sometimes in the exam, the examiners will cut you off when they see that you're saying everything and that you know your stuff. They'll just cut you off and move to the next question. So if they do that, don't feel like it's anything bad.
Okay.
So how do you advise diabetic patients on diet and exercise?
So with diet and exercise, if they are A1 diabetics, with diet, it's very important to cut down on sugar, still have a balanced meal. They should have 3 meals with 3 snacks, but keep a very healthy diet. As for exercise, they should do around, a very light exercise, not too heavy or not CrossFit or anything, but around 150 minutes per week in order to stay active and keep the diabetes under control. And we should watch her sugar so that we know that she's not developing A2 diabetes.
What should your readings be to
So
decrease the risk of macrosomia?
right. So what should the sugar readings be before so that they don't develop macrosomia?
Correct.
I'm not sure what the cutoff is when it comes to sugar. I know that in order for them to develop A2 diabetes, they keep a certain journal of monitoring her sugars in the morning and after meals, and 80% of those values should be normal in order for them not to be diagnosed with A2 diabetes, which would put them at risk for macrosomia.
Okay. So fasting should be less than 95. The 1 hour should be less than 140, and the 2 hour less than 120.
Yes.
So those should be achieved to decrease the risk of macrosomia. The 1 hour postprandial measurement for managing GDM was associated with increased LGA, cephalopelvic disproportion, and increased risk of C-section when it's consistently elevated.
Okay.
What are some, when we talk about managing diet, we advise the patients that they need to take 3 meals, 3 snacks to distribute the glucose intake and decrease the postprandial fluctuations. And how do you tell them about what are the percentages of the carbs and the fat versus the protein in their diet?
It's usually 1/3, 1/3, 1/3.
Okay, so like 30 to 40 carbs, like 40 fat, and like 20% protein.
Okay.
Okay, but how do you, I know you don't do this, but again, one of the things they ask you in the exam and they expect you to know how it's done, even though you don't do it, is managing insulin.
Right.
Do you know what they're, if you are gonna start them on insulin, how you're gonna dose it? How do you start them on insulin?
So usually if we're starting on insulin and they haven't been on insulin, it's usually trimester dependent. So let's say they are in the first trimester, it's 0.7 units per kilogram, and then it goes up 0.8 units per kilogram, and then 0.9 units per kilogram in the third trimester, and that would be the total amount of insulin they need throughout the day.
Okay. So the first trimester, they would need 0.7 to 0.8 units per kg per day. Second trimester, 0.8 to 1 units per kg per day. And the third trimester will be 0.9 to 1.2 units per kg per day. And AM dose is 2/3 of the daily dose. PM dose is 1/3. And the AM dose is further divided into 2/3 MPH, 1/3 regular. And the PM dose is half MPH and half regular. Let's
Yes.
talk about White's classification.
Okay. So yeah, go ahead.
Tell me what White's classification is,
Sure.
please.
So White's classification is we start with A1 diabetes, which is a diet control diabetes. A2 diabetes is when we add insulin to the regimen. B is when they've had diabetes for less than 10 years and they were diagnosed beyond 20 years old. C diabetes, they've been diagnosed for more than 10 years and they were diagnosed, I think, before they were 20 years old. And then D diabetes, I believe they were diagnosed when they were younger, I believe less than 10 years old. There's the R classification when it comes, that's when there's nephropathy.
What kind of retinopathy?
Sorry, retinopathy. What's that?
Which one? Which one, benign or proliferative?
I'm gonna say proliferative.
Okay. So the
Okay.
benign retinopathy is part of D, and the
Okay.
proliferative retinopathy is part of R. Okay, keep going.
Okay.
Sorry.
F is nephropathy. H is for heart disease. Is there any other letters? I can guess if you tell me the letter.
F, H.
So F is nephropathy, H is heart, and R is retinopathy. I can't remember if there's anything else.
And T.
What's that?
E.
E?
T.
T. Um, T.
Renal transplant.
Transplant. Okay, I forgot about that. Okay.
That's fine. You did good. A lot of people don't
Okay.
remember the Whites because we don't really use it, but it's one of those things that the examiners like to ask you because they want to see if you know it or not.
Okay.
Okay, so when we talked about counseling the patient with GDM on the effects of pregnancy, what about pre-gestational diabetes?
With
What are some
pre-gestation,
effects if they're not well controlled and they get pregnant?
right. So with pre-gestational diabetes, there's a lot of overlap between the two effects of diabetes, but mainly we are very concerned about congenital malformations such as neural tube defects, as well as neural tube defects such as spina bifida, for example, limb defects, cephalocaudal syndrome, and heart disease that can happen like as congenital malformations in the baby. It can also cause IUGR as well, and they are at high risk for DKA throughout the pregnancy.
Okay, so yes, so congenital malformation are increased 2 to 6 folds. And there are cardiac like ASD, VSD, transposition, which are the most common, skeletal, CNS like neural tube defects and holoprosencephaly, and caudal regression.
Okay.
Also, those patients could be either IUGR or LGA or IUFD.
Yes.
And then after they are born, a lot of hypos, hypothermia, hypocalcemia, hypoglycemia, hypomagnesemia, and then like hyperbilirubinemia and polycythemia. How do you manage? That's an important question that they ask. They actually asked me that question in my oral board exam. How do you manage gestational diabetic on insulin and active labor, or the night before the induction leading to active labor?
With during labor, usually we measure the insulin level every 4 hours in the latent phase, and then every hour during the active phase, because we need to make sure that her glucose level is not too low or too high.
Okay, so you're measuring it every hour. What's your goal blood sugar?
The goal blood sugar is, I believe, between 80 and 120. No, sorry. Between 60 and, I think it's 60, between 60 and 120.
Pick one number. Can you pick one number?
But no, I'm saying it's between, so above 60.
So your goal blood sugar, what you want to keep the blood sugar out during active labor, is 100.
Okay.
Easy to remember. It's just 100. What kind of fluids do you give them during active labor?
Sorry, you said above 100?
It's around 100. Should be around
Around
100
100.
milligrams
Okay.
per deciliter.
Okay.
What kind of fluids are you gonna give?
Normal saline or LR. I remember in my institution we looked it up, but LR does not increase any the risk for DKA or increasing glucose, so it's either normal saline or LR.
When do you give D5?
If they're hypoglycemic, less than 60.
Okay. How do you manage them during labor? How do you keep the blood sugar at 100?
So by measuring it every hour during the active phase, and either giving normal saline or D5 if they are not achieving that goal.
What if they're on insulin pump? How do you manage them?
So that's usually also, they measure the glucose, and there's a certain measurements that they need to adhere to. So they give insulin every hour according to what their glucose is.
Right. And how would you manage their blood sugars after they've delivered?
Usually after they delivered, because we've delivered the placenta, their needs are cut down by half. So they get half the insulin of what they do get, and that's usually for patients who are usually on insulin. Usually A1 and A2 diabetes should not require any insulin after they deliver. However, in my institution, we used to at least measure the fasting glucose just to make sure that there's nothing that we missed. However, if they are diabetic, if they are on a pump or on high amounts of insulin, usually we cut the insulin by half. We do recommend that at their postpartum visit at 6 weeks, if they were A1 or A2 diabetes, to do a 2-hour challenge test to make sure that they did not develop diabetes.
Okay, so on the day before the IOL, you give the usual night dose and you withhold the morning dose. You would start D5 when the blood sugar is less than 70 or when inactive labor begins. If the blood sugar is more than 140, you're going to start the insulin drip. You're going to give a rate of 1 unit per hour. You're going to titrate it to maintain adequate blood sugar control at above or just at 100 milligram per deciliter. For patients with insulin pump, you're going to start the insulin at 0.5 units per hour, adjusted from basal rate to maintain good control. And after delivery, just like you said, you cut the dose either to a third or to half and see how she does with that and adjust accordingly. What are some risk factors for DKA? You just mentioned DKA. DKA could come as like a case of the day.
Right. So with DKA, the risk factors is, of course, previous episodes of DKA. Type 1 diabetes is definitely a risk factor for DKA. If they are diabetic and they developed an infection, they can go into DKA. If they miss their insulin dosage, they can develop DKA. Those are the main risk factors that I can think about right now.
Right. And what is the mortality rate with DKA?
If untreated, I believe it's around 20%.
Yeah, a little bit higher, like maybe 10 to 35%. So it's
Okay.
a life-threatening emergency. Okay, so risk factors would be new onset diabetes, infections, like you said, COVID, flu, UTIs that are left untreated, poor patient compliance, or maybe patient on a pump and the pump is not working well, or if you treat the patients with some medications that can mess up their blood sugars, like what?
Medications that can mess up their blood sugars.
Like steroids
Okay. Yes. Yes. Yes.
and like beta mimetic tocolytics like terbutaline.
Yes.
So if they have DKA, how do you manage?
Oh, we're gonna go into that. Okay, so with DKA, of course, we the most important thing is giving lots of fluid in the beginning. If they have their glucose above 250, usually we start with giving insulin in order to decrease it, as well as 3 liters of fluid. Of course, we do get ABGs, we do get a CMP to make sure that their electrolytes are balanced. We make sure that there's no infection that is causing this DKA. We monitor their sugars over the next few hours. Once they're below 250, I think we start D5 half saline, and we keep titrating their insulin until their glucose is normal. But I believe we do give about 3 liters of saline at first, and then 1 liter of insulin after that, 1 liter of saline after that.
Yeah, so you give a lot of fluids. You give 4 to 6 liter bolus in the first 12 hours, 1 liter in the first hour, half a liter for the next 2 to 3 hours, then 250 ml per hour until 80% is replaced. Then mainly you're going to do aggressive hydration and you're going to give insulin with it. And so the insulin loading dose 0.2 to 0.4 units per kg, and the maintenance is 2 to 10 units per hour based on what your blood sugar is. And then you're going to give glucose. You're going to give D5 once your blood sugar hits 250. You're going to replace potassium if it's normal or low. You give 15 to 20 milliequivalent per hour, or if it's high, then you wait until it normalizes, and then you give 20 to 30 milliequivalent per hour. And bicarb, you're going to give if the pH is less than 7.1. Last questions on GDM. Those are most likely all the questions that they will ask you, and I doubt they will ask anything else. We covered almost everything. When she
Yeah,
comes
whole
in the
chapter.
when she
Yeah,
comes in the postpartum visit, you're doing really well, by the way.
thank you.
So, how do you manage them postpartum when they come in the 6 weeks visit?
So usually so I usually follow up to see if they are on insulin, how was their intake of insulin. If they're not on insulin, usually what we do with A1 and A2, you said GDM, sorry. So with GDM, we usually do a 2-hour glucose test to make sure that they did not develop diabetes, because that needs to be monitored.
Okay. So what do you do? The 2-hour test, what are the cutoffs for the 2-hour test?
Um, it's hold on. I believe it's 75-gram glucose. I believe it's just like the others. It's 140 and 120.
No, so the fasting should be less than 126 and the 2 hour should be less than 200.
200. Okay.
So if they're both elevated, then she's diabetic. You refer her to primary care to help her out. If they're negative, you're just going to repeat the testing every 3 years to make sure she doesn't get diabetes, because now she's at higher risk.
Okay.
If it's impaired, like only one of them is elevated, then you're going to advise weight loss, medical nutrition therapy, maybe metformin, and you'll repeat the testing every year.
Okay. You said 126 and 200. Okay. So that I memorized them. Okay. Okay.
Fasting is 120, should be less than 126, and the 2-hour less than 200.
Perfect.
Okay, Hadi, thanks a
All
lot
right.
for.
Thank you so much.
It's great.
Thank you.
Thanks. Okay, I'm gonna call on somebody else. I see Maya here. I'm gonna unmute you, Maya. Hi, Maya.
Hello,
How are you?
I'm doing well. How are you?
Good. Are you a general? General?
Yes.
Okay. Where are you at? Let me pull up
My
your.
list is going to be in September under Rolfe, ROLFE.
What do you mean? Your case list?
Yeah, my case list.
I found it. Isn't your last name Dominic? Not sorry.
It's under Rolfe, but it's going to be in the September.
Why? Why they didn't put it in the October one?
I think because I submitted it in September.
Okay. So the last name is gonna be Rolf?
ROLFE.
Where is it?
Here it is. It's above. Oh, you stop. No, go up.
Oh, here it is.
Yeah.
Which one do you want to go over? Which case list?
Office.
Okay. Do office. You have anything in your office case list that worries you?
I would say something from the end.
Is there any particular case? Let's talk about postpartum depression. Going from, you want to talk about that, or do you want to talk about HRT?
We can do, because I did that one before, the HRT. HRT. I don't know about depression. What about, or like the vaginal bulge, like the POP-Q is sort of hard for me. And then
which one is the vaginal bulge one? Let me see.
Vulvar disorders. Yeah.
Okay. Why don't you tell me about the POP-Q? You asked for it.
I did. So I have a question. If on the test, because we have that paper, would it be okay for me to like write it out versus to say everything so they can at least see that?
Yes, it's okay. You can have, if you have a paper in front of you and a pen and you're trying to describe something and you say, but you have to ask them first before you start writing. You can say, can I draw it and show you? And if they say yes, go ahead, then do it. Otherwise, I wouldn't do anything without asking.
Got it. Okay. So in relation to the POP-Q, it is going to assess pelvic organ prolapse. There are different areas for pelvic organ prolapse. It can be a central prolapse. It can be an anterior compartment prolapse or posterior compartment prolapse.
Okay. So POP-Q comes in stages, right?
Yes.
And also there's the one where you, the quantification system. So tell me the quantification system, the POP quantification system. Do you know it?
Yeah, I do. So on the POP-Q, I basically draw out my squares. You want me to tell you the numbers, or can I go through the squares with you?
Do whatever you want. Imagine that this is the exam and I just ask you this question. So if I don't like what you're saying, I will cut you off and redirect you to where I want you to go.
Okay. So in relation to your quantification system for POP-Q, if your leading edge is at -3, that means you have no prolapse. Stage 1 is going to be between, the leading edge is going to be greater than -1. Stage 2 is going to be between -1 and +1. I'm sorry, I think I said that too fast. Sorry. Zero is your leading. You have no prolapse at all. Stage 1 is your leading edge is, yes, greater than -1. Stage 2, it is going to be between -1 and +1. Stage 3 is going to be greater than -1, however, less than the total vaginal length -2. And stage 4 will be the total vaginal length -2.
Okay, how does that differ from the Baden-Walker pelvic organ prolapse classification?
The Baden-Walker is more in relation to where it is in relation to your vagina and all the way to the complete procedentia. So stage 0, it's no prolapse. Stage 1 is the leading edge is going to be -1. Stage 2, it is going to be between -1 and right outside of the introitus and +1. Stage 3 is going to be +1 and also it's going to be beyond +1, and stage 4 is going to be complete procedentia.
Okay. And so the POPQ is based on the maximum descent of the prolapse relative to the hymen in one or more compartments. So stage 0 is where no prolapse, where all points are -3. Stage 1 is where the distal prolapse is more than 1 centimeter above the hymen. Stage 2, the most distal prolapse is between 1 centimeter above and 1 centimeter below the hymen. Stage 3, where the most distal prolapse is more than 1 centimeter below the hymen, no more than 2 centimeters less than the total vaginal length. And then stage 4 is the complete procedentia. What are some risk factors for women to have pelvic organ prolapse?
Risk factors include obesity, COPD, someone with multiple children, vaginal deliveries, someone that has increased pelvic pressure, maybe they lifted weights during their lifetime, like a weightlifter. That's what comes to mind.
Okay, so genetic predisposition also plays a role. Parity, menopause, advanced age, if they had pelvic surgeries before, they have connective tissue disorders, or if they have anything that will cause increased intra-abdominal pressure that will make the organs prolapse, like obesity, chronic constipation with excessive straining and stuff like that. How do you evaluate pelvic prolapse by exam?
So when I evaluate pelvic prolapse by exam, I do it with my patient in the dorsal position, dorsal lithotomy position, as well as standing. So when they're in the dorsal lithotomy position, I have the patient Valsalva, and at that time, I look to see if the prolapse does come out of the vagina. If it does not, I then do a vaginal exam, and I have them also Valsalva again to see how far, if they have like a central prolapse. The way in which I evaluate anterior and posterior prolapse, I take a speculum and I separate it, and I place one blade on the posterior aspect of the vagina, and I have them Valsalva to see the anterior compartment prolapse. And then as far as the posterior compartment, I evaluate that by putting the blade on the anterior aspect of the vagina, have them Valsalva to see if they have any posterior prolapse.
Okay, and so what are some treatment options for prolapse? Well, first of all, I want to say something. When you talk about evaluation of pelvic prolapse, it involves 5 compartments: the uterine prolapse, anterior compartment prolapse, as in cystocele, posterior compartment prolapse, so anything below the rectovaginal septum as the rectocele, anything above as an enterocele, and then evaluation of the outlets, where you evaluate the perineal body and the levator muscles. And so what are some treatment options for prolapse?
So for prolapse, I typically start my patients with more conservative measure. So I talk to them about Kegel exercises and make sure that they're doing it appropriately. I also refer them to pelvic floor physical therapy. In addition, I can give vaginal estrogen, and also I talk to my patients about potentially a pessary.
Okay, good. So how do you discuss pessaries with those patients?
So I talk to my patients about pessaries and tell them that this is a particular, it's different types of pessaries that they can use. These pessaries are something that they can put in themselves and take out themselves and clean, as well as it is something that they can come to my office that I can support them with. I do tell them that the pessary, I will fit it for them to see how it feels. They should not feel the pessary at all. In addition, I talk to them about some of the disadvantages that can come along with pessaries, that sometimes it can cause erosions. So it is good for us to at least evaluate the vagina at least every 3 months, and for them to let me know if they're experiencing any discharge or any vaginal bleeding.
What are the categories of pessaries? What are the kinds?
You can have a ring, you can have a ring with support. You can also have like a ring with the knob. You can have the Gellhorn. You can have like a cube.
So categories, what was in my mind when I asked you these questions, I was thinking supportive, as in ring pessary for pregnancy, for example, or Gellhorn. And then there's the space occupying ones, which are the donut, the cube, and also the Gellhorn. The commonly used ones are what?
Say that one more time.
The commonly used pessary is what? Which ones do you commonly use?
Oh, I typically use with my patients that still have a uterus in place, a ring with support.
Okay, so for stage 2 and 3, the ring is a good option. For stage 4, the Gellhorn is a good option. It's more space occupying and bigger, or maybe the donut and the cube. And so, what are some complications with pessaries?
So complications can be increased vaginal discharge, as well as vaginal irritation. It can also cause erosions if the pessary is left in, and worse, it could actually cause a fistula.
Okay, so vaginal ulcerations or abrasions, it could migrate to adjacent viscera if left in for a long period of time, like an elderly woman who don't have like somebody to care for them. It could cause vaginal discharge, vaginal spotting, could spontaneously come out, and it could also cause some pap test abnormalities, which are related to inflammation. Have you heard of levels of vaginal support, the Delancey levels?
I believe if it's the levels 1, 2, and 3,
Correct. Do you know them?
it's in relation to the like the ligaments, supportive ligaments, but I wouldn't be able to say it off the top of my head, no.
Right. And so sometimes they ask this question, not very often, but it's one of the questions that could be asked. They could ask you what are the levels of support, levels of vaginal support, which they call Delancey levels. So level 1 is the suspensory axis, and that supports the upper and proximal vagina, and usually supported by cardinal and uterosacral ligaments. And if there's a defect in this level of support, then those patients usually have an apical prolapse or an enterocele. Level 2 is the attachment axis, and it attaches the mid-vagina along its length to the arcus tendineus fascia. And if there's a defect in level 2, then that could cause a lateral wall prolapse, so paravaginal prolapse. And then you have level 3, and that's the fusion axis, and that is where there's fusion of the distal vagina to the adjacent structures like the perineal body and the perineal muscles. And if there's a defect there, then this patient could have anterior and posterior vaginal wall prolapse and perineal descent. So this patient of yours in this case 35, you just, what did you do with her? No, sorry, that's not 35, 36.
Yeah, so
You just right?
yeah, I just did the ring, yes.
Okay. Let's talk about what's the time? Okay, I'm gonna call on somebody else if that's okay, Maya. You did really good for a topic that you wanted to talk about because you're not good at. I don't know, you guys. Very good, excellent.
Thank you.
Sure. Okay, let's go. And I'm gonna call in who I haven't talked to before. Ruth Wagner. Hi, Ruth.
Hello.
Hi.
Hi.
Are you a generalist?
I am, yes.
Okay, let me pull up your case list. Where do you practice? Let me go back to
In
October.
Ohio,
Okay, nice.
and it's gonna be under Claros.
Claros?
Uh-huh.
I don't see it. I see the C here. Chopra.
Right, but you're almost there.
There it is,
Right.
right?
Yes.
Which case list do you want to go over?
Since we just did office and OB, we can do GYN.
Okay. Okay. Is there anything on this case list that worries you?
No, I mean, I anything is fine.
Sorry, I'm trying to flip through all the stuff. What about, well, recurrent pregnancy loss, I would ask you about that, but it's, why did you do hysteroscopy DNC on her? Just for like a missed abortion?
Actually, no. So, at our institution, we actually are in a fairly rural place, and so we don't have access to SIS or HSG. The patient was counseled about referral to REI in order to get an SIS to validate the uterine cavity, and she declined, and so then she was offered the hysteroscopy DNC as a way to validate the uterine cavity.
Okay, to see why she has recurrent pregnancy losses?
Correct, yes.
Okay, so this is not really GYN but OB, but let's talk a little bit about recurrent pregnancy losses. So what is the definition of recurrent pregnancy loss?
So it's when you have 3 or more losses in the first trimester, but you can begin the evaluation after the patient has had more than 2 recurrent losses.
Okay. And so what are some causes of recurrent pregnancy loss?
Yeah. So usually I like to think of it in like usually there can be uterine abnormalities that are causing it, so like a uterine septum, or any other or like it's like a submucosal fibroid or something in the uterus. It could also be due to chromosomal stuff with the fetus. It could be chromosomal issues with the parents, or it could be other endocrine like antiphospholipid body syndrome, as well as some other endocrine abnormalities.
Okay, so causes could be unexplained. They could be chromosomal, so like
Mhm.
recurrent, like aneuploidies or something like that. It could be congenital uterine anomalies like a septate uterus or a bicornuate uterus. It could be autoimmune like antiphospholipid syndrome. Could be metabolic like diabetes, PCOS, hypothyroidism. Could be infections like listeria, toxoplasmosis. Could be environmental like smoking, alcohol, cocaine use. So those are some of the causes. So who do you offer testing to, and what tests do you offer?
Mhm. So like I said, I usually will begin evaluation after they have had 2 recurrent pregnancy losses. Um, and so usually we begin with if they're able to, like if the loss occurred and we were able to do a DNC, we can send that tissue off to pathology and start there. You can also do antiphospholipid body testing. We usually do a thyroid screen, a diabetes screen. Also do, I think those are the major ones that I can think of right now as far
Right.
as the evaluation.
You would offer the testing if the patient has more than 2 losses, can do karyotyping, HSG, sonogram, or hysteroscopy, which you offer this patient hysteroscopy. Labs, HbA1c, TSH, urine toxicology should be sent as well, lupus anticoagulant, RPR for syphilis. What about inherited thrombophilias? Would you order those?
I would not order those. I don't believe that they are recommended right now by the Society for Reproductive Medicine.
Right, there is insufficient evidence to support inherited thrombophilias or thyroid antibodies and stuff like that. How do you counsel patients regarding intra-pregnancy interval after early pregnancy loss? What do you tell them?
So I usually tell them, first off, like, be sure that they're emotionally ready to try again, depending on when they had their loss and if they had to have a procedure. I usually tell them to wait about 2 to 3 months before trying again. And I usually counsel them that they should let us know when they get a positive pregnancy test so that we can follow them closely with serial beta HCGs, just so that we can, like I said, like closely monitor them.
Okay. If you had a patient with early pregnancy loss and you would like to do medical management for her, what are her options for medical management? She's miscarrying.
So her options would be vaginal Cytotec, 800 micrograms times 1 dose. If they don't have results within the next 48 hours, then you can give them a second dose of the vaginal Cytotec. There are places that use mifepristone, but you have to have a special, at least where I practice, you have to have a special license to give mifepristone.
Sorry, so you can give me misoprostol, 800 mcg/PV with 1 repeated dose as needed within 7 days of the first dose, and you can also give mifepristone. You say you can't give mifepristone where you practice?
No, you have to have a special license.
Okay.
Mm-hmm.
Okay. Let's move on from recurrent pregnancy loss and let's talk about. I've been looking at your case list, so you have a lot of postmenopausal bleeding, but I've talked about that a couple times before, so I don't want to repeat that. But I'm very curious about those 2 patients, 28 and 29, that are 17 and 20, whom you both done a laparoscopy on. Can you tell me a little bit about what kind of pain they were having? You also didn't find anything on the laparoscopy. And what
Correct.
medical management did you mention that was failed?
Yeah. So for my pelvic pain patients, and actually for well, specifically for case 28, she was a patient that presented to me after having been treated by a previous OBGYN with 2 different birth control pills. She was very frustrated because her pain was almost on an everyday basis. It was so significant that she was unable to attend school most days. She had a significant family history of endometriosis. And so usually what I try to do is I try to make sure that they've tried at least 2 or 3 different birth control pills with different progesterone components to see if that can help them. And if that doesn't help, then I usually try to counsel them about Depo-Provera or the progesterone IUD. And if I don't have any success with that, then I counsel them about performing a diagnostic laparoscopy. Just to see if I can get a diagnosis for endometriosis.
Okay. What about the other one, 29?
I believe this patient was also I believe she had also a significant family history of endometriosis, and she had tried 3 different birth control pills. She did not actually want to try the Depo or the IUD. She wanted to go straight to a diagnostic laparoscopy. after having failed the OCPs.
So after you did the diagnostic laparoscopy and you found nothing, what did you do for her?
So then I counseled her on pursuing progesterone IUD, which actually after the surgery she was amenable to trying that.
Okay, so she did a progesterone IUD afterwards for pain?
Correct,
Did that
yes. Actually, I've seen her once in the clinic after that, and it has helped her pain quite a bit.
Okay. So is it fair to say that that patient, the 17-year-old who does not have endometriosis, probably has just dysmenorrhea?
I guess for dysmenorrhea, I would describe the pain as being like either like during their period or before her period. It was very unusual for her to have pain like most days of the month.
So she had pains not just during her period, but throughout the month?
Correct, yes.
So let's assume that this is the dysmenorrhea case. What is the difference between primary and secondary dysmenorrhea?
I would say primary dysmenorrhea is the way I understand it is that you've had painful periods or pain during your periods ever since you started having menstrual periods. Secondary dysmenorrhea is your painful periods began not when you started having menses, but after some other event, or just started later in life, I would say.
Right, so the primary is where there's no identifiable pathologies, diagnosis of exclusion, and secondary is usually associated with endometriosis, leiomyoma, PID, adenomyosis, polyps. And so how do you treat it? How do you treat dysmenorrhea?
I usually treat dysmenorrhea with medical management using hormonal therapy. So I start with contraceptive pills, and then, but I also offer them the other methods, like LARC methods as well.
Okay, so you can give them NSAIDs, and that's actually very effective because it decreases prostaglandins.
Yeah, I need to
You can give
remember the
ibuprofen.
yeah.
You can give ibuprofen 400 milligrams every 4 to 6 hours, or naproxen 500 loading dose and then 250 every 6 to 8 hours. Or you can give them mefenamic acid 500 milligrams, also loading dose, and then 250 every 6 to 8 hours. You can also offer them extended birth control pills if cyclic are not helpful. They can do Depo, they can do Mirena, which seems like that's why I asked you if you think this is a dysmenorrhea patient, because it seems like it might be. They can also get GnRH agonists as well because that leads to endometrial atrophy and decrease in prostaglandin, but it's not a very favorable option for patients with dysmenorrhea.
Okay.
Okay. Ruth, I'm gonna call on somebody else because they asked us to do 15 minutes with each candidate, so more people can be on the hot seat. So thank you very much. And I'm gonna call one last person before we finish. 10. And I will only call people who raise their hands. So I have Kristen Beetham. I know I have a couple more people who have raised their hands, but I'm sorry I don't have time to call everybody tonight or maybe next time. But I'm gonna call Kristen. Kristen Beetham.
Hi,
Hi, Kristen. How are you?
I'm well. How are you?
Good. Are you a generalist or are you a fellow?
I'm a generalist.
Okay. Where do you practice? Let me pull up your case list.
I practice in New York.
It's like New York, New York.
Long Island.
Okay.
So
I
in a large hospital.
finished my residency in upstate New York. Then I moved to
Oh,
Michigan.
I
I
just
miss
moved
it.
to Boston actually.
Yeah.
So
Okay, well,
a
I
little
can't
different.
find you. Where is it? Where they usually go alphabetical, but maybe I'm wrong. But no, they're not alphabetical. Let's see
Yeah,
here.
it should be under Beetham. Yeah.
Yeah, found it. Which one do you want to go over? Which case list?
Let's do OB. I have a
Okay.
pretty large list. So any case you want to pick.
Okay, let me just take a look real fast. Let's talk about fetal growth restriction, because I haven't talked about that with you guys for a while. I don't know what the other people discussed. Have they talked about this recently? Because if they did, I'll look at something else.
I don't think so.
Okay, let's talk about FGR. So tell me the definition of fetal growth restriction.
So fetal growth restriction is defined as an estimated fetal weight less than the 10th percentile, or an abdominal circumference less than the 10th percentile. Each of these is based on gestational age.
Okay. How do you differentiate between symmetric and asymmetric IUGR?
So symmetric IUGR would be where the indices are all decreased kind of along the same growth curve. Whereas asymmetric IUGR would be, you have usually it's sparing like the head, and it's more associated with an insult later on in pregnancy.
Okay. So yeah, so which one is the most common one?
The most common, I believe, would be asymmetric IUGR.
Correct. So 70 to 80% of IUGRs are asymmetric and the rest are symmetric. And those asymmetric IUGRs are usually in the third trimester, where there's usually head preservation, where the abdominal circumference is less than 5, and there is increase in ratio of head circumference to abdominal circumference. Could also be due to placental and maternal vascular factors. And it definitely has lower morbidity and mortality than the symmetric, which starts in the first trimester and usually caused by congenital anomalies or trisomies or infections that has higher morbidity. How do you manage a patient with IUGR?
So I would definitely be seeing the patient more frequently in the office. I would want to evaluate for possible causes of the IUGR. In general, after having a diagnosis of IUGR, I would want to continue from that point forward with serial growth ultrasounds about every 2 to 3 weeks. And with the growth ultrasounds, I'd be monitoring the umbilical artery Dopplers as well. I'd also want to initiate antepartum testing with BPPs and STs, and looking at for any signs of oligo or reversed flow on the umbilical artery Dopplers.
Okay, at what point would you give steroids to IUGR babies? And at what point would you give MAG?
So if there was concern for delivery within the next 7 days, I would give a course of betamethasone or steroids. If it was less than 37 weeks. Additionally, I would give magnesium sulfate for neuroprotection for babies less than 32 weeks that I was concerned for preterm delivery.
When would you deliver an IUGR baby?
So that would depend on the percentile and the presence of abnormal Dopplers. For this specific case, the EFW was at the 8th percentile. So anything between the 3rd and 10th percentile, you can deliver between 38 and 39 weeks.
Okay. Wouldn't you deliver them earlier than that if they have IUGR?
With IUGR with normal Dopplers, if they're above the 3rd percentile, I believe you can deliver as this patient was 38 to 39 weeks.
What about 34 to 37 weeks? Would you deliver them then? What would be the criteria if you decide to deliver them earlier?
So if was going to deliver them earlier, if it would be because they were either less than their estimated fetal weight or abdominal circumference was less than the third percentile, or if they had abnormal Dopplers. The earliest I would deliver would be 32 weeks for a reversed Dopplers.
So let's say you have a patient, well, so basically IUGR with risk factors. So if isolated IUGR, you're going to do 38 to 39. If IUGR with risk factors, what are some risk factors like abnormal Dopplers, maternal risk factors, or oligo? Or if the abdominal circumference is less than 30%, then when would you deliver? What if you just have an IUGR with an abdominal circumference of less than 3%? When would you deliver her?
At 37 weeks.
Okay. When would you deliver di twins with IUGR?
I'm not certain, but my best guess would be at 34 to 37 weeks, but I would have to confirm that.
So if there's an isolated IUGR 36 to 37 weeks, if IUGR with risk factors or with mono-di twins, so 32 to 37 weeks, depending on what's going on and on the risk factors. What are some complications of babies that are born to IUGR? Complications of babies that are IUGR after birth?
So they can have issues with, well, preterm the complications of prematurity if they're delivered before 37 weeks. They can have complications with thermoregulation, hypoglycemia, and let's see, I'm having a hard time thinking of other issues that they might have.
So hypoglycemia, hypothermia, hyperbilirubinemia, intraventricular hemorrhage, necrotizing colitis.
Oh yeah, all the complications.
Right, like also for preterm as well, right?
Okay, yeah. So I can just go through the preterm delivery.
Yeah,
so go through like the complications of prematurity.
Correct. What are some causes of IUGR? We talked about symmetric or asymmetric, but if you would want to be more general and just talk about causes of IUGR, what would you say?
Okay. So I usually think about them in terms of maternal, fetal, and placental causes. So fetal causes of IUGR could be, chromosomal abnormalities, as we previously discussed, or placental causes could be anything that could cause decreased placental perfusion, such as if you had like a chronic abruption, or if you had single vessel cord, or any infections in the placenta. So any of the like syphilis or CMD, toxoplasmosis. Also, you could have maternal causes, which could be from hypertensive disorders of pregnancy, diabetes. Generally, this would be pregestational diabetes, substance misuse, and infections in the mother, like pyelonephritis.
So think about it as maternal, fetal, but also you can think about placental causes and cord causes. So maternal, a lot of the stuff that you mentioned, hypertension, diabetes, any chronic illness like cyanotic heart disease, SLE, renal, substance abuse, teratogene exposure. For fetal, could be like you said as well, infections, twin pregnancies, chromosomal anomalies. For placental, it could be placental insufficiency, abruption, hemangioma. And for cord causes of IUGR, could be like single umbilical artery, filamentous cord insertion, and so on. What can you tell me about single umbilical artery? What would be our concern in the ultrasound, if we have a patient with a single umbilical artery, how do you counsel those patients about this finding? What do you tell them?
I'm I know that it can often these patients, they're seen at our with our maternal fetal medicine specialists because they're the ones doing the anatomy exams. But to the best of my understanding, it could be associated with certain congenital anomalies or syndromes, as well as fetal growth restriction.
Okay. So 75% of babies who have single umbilical artery are normal and healthy. 25% of those are babies that have heart disease, renal disease, skeletal disease, or intestinal disease. It is associated with IUGR. That's why I mentioned it with IUGR. It affects 1% of pregnancies. The major malformations would be like renal aplasia, lymph reduction, or atresia of organs. And the risk factors that are associated with it would be like it's increased with diabetes, with epilepsy, preeclampsia. It's also associated with oligo or polyhydramnios. So just to be aware, those patients, they have a high risk. They need, in the anatomy scan, look out for these things, and also that she needs to be monitored closely for the risk of IUGR during the pregnancy.
Okay.
Okay. I guess our time is over. Does anybody have any questions about anything related to what we talked about or not related to what we talked about? Anybody has any questions?
I was wondering,
Go
I
ahead.
had a question about our case list, and not necessarily for OB, but for, say, GYN, if there were labs that we got for the workup for a patient that really, now that we're looking back, we aren't, perhaps we wouldn't have gotten those labs. Is that something that you would mention?
Only if
Like,
they
would you say
ask you.
something?
So if you
Okay.
did something on your case list that once you studied more, you realize, oh, I shouldn't have done that. Why did I do that? Best if not to say anything, but if they ask you, why did you do this and what was the significance of this, you say, I realized that was not the ideal way of dealing with this patient, and if I would do this over again, I would do this and this differently. I would have not done this.
Okay.
I would have done this, and that I learned from this. I realized that this is not what I should have done, and I would have done it differently this way. So don't never say anything about your mistake unless they bring them up. But if they do bring them up and they ask you why you did something and you know you shouldn't have done it, just admit to your mistake and say, I shouldn't have done that, and this is what I would have done differently. That'll be it.
Okay. I mean, for like minor things like labs, maybe like FSH or whatever, or AMH, if it wasn't cost effective, that's my biggest concern. I don't know how picky they are on that.
It all depends on what the examiner is like. Some of them are so friendly and so nice, they will not do that to you. Others will probably just enjoy picking at you a little bit. It will not make you fail the exam. Honestly, really, they have a lot of questions to ask. That's probably just going to be something that they do just to see what your reaction is.
Okay.
You should be fine. Just say, I understand that this is not cost effective. I probably shouldn't have ordered this, but I did, and next time I won't order it.
Okay. Thank you.
Okay. I wish you all the best. This is a very difficult time preparing for the oral board exam. Just keep doing what you're doing. Study hard. It will all pass. It will be a memory. Do your best, and hopefully this will end soon. Good night. I wish you all the best. Bye.
Bye. Thank you.
Sure.